Welcome to ECG Basic Part 3. Here today in this Part 3 we'll talk about QRS complex. QRS complex. As the name implies, it consists of three things: Q wave, R wave and S wave. Q wave is the first negative deflection after the P wave. This is Q wave. Q wave is the first negative deflection. And this is, let us see. Q wave is the first negative deflection. This is Q wave. And after the Q wave, this first positive deflection, this is R wave. And after the R wave, the negative reflection, this is S wave. S wave is, this much is the S wave. And as a whole, QRS complex I have already mentioned in the ECG Basic Part 1. QRS complex represents ventricular depolarization. Let us start with Q wave. Q wave, among the QRS complex, we'll talk about the Q wave first. Q waves can be physiological or pathological. Physiological or pathological. Normally, physiological Q wave is seen in lead 3, ABL, P5 and P6. This physiological period normally देखा जाए lead 3, ABL, P5, P6 से देखा जाए. Normally it criteria की criteria I would say what is the criteria? That is normally it is seen criteria I would say it is the depth should be less than 3 small square. Small square. In this physiological Q wave, which depth is less than 3 small square is properly visualized in lead 3 during the deep inspiration. If person do not take the deep inspiration, in expiration this physiological period may be absent, and it is normally present in the lead ABL, P5 and P6. This is physiological Q. And if its length becomes, its depth becomes more than 3 small square, that condition is called pathological Q wave. Pathological Q wave depth when it increases more than 3 small square, that condition is called pathological Q wave. This pathological Q wave occurs in ischemic heart disease. It occurs in myocardial infarction. Myocardial infarction, if the Q wave is seen in inferiorly 2, 3 ABL, it suggests inferior wall EMI. Inferior wall myocardial infarction. Okay, and if occurs in 1 ABL, P5 and P6, that is lateral wall EMI. Lateral wall. So pathological Q wave, if it is more than 3 small square in depth, 3 square in depth is called pathological. If seen in 2, 3 and ABF is inferior wall EMI. If it is seen in one AVL B5, B6, that is lateral wall EMI, and if it is seen in B1 and B2 only, that is anterior wall EMI. If it is seen in B3 and B4, that is septal wall EMI. If it is seen in all leads B1 to B6, this is extensive anterior wall EMI. Extensive anterior wall EMI. So pathological cues according to the site represents the which wall EMI. It is according to the lead, it represents the site of the EMI. Now, what about now come to the height of the R wave? Height of R wave. The height of the R wave should be in the limb leads. It should be more than 5 millimeter. Then height should be more than 5 millimeter. In the chest leads, the height should be more than 10 millimeter. Limb leads more than 5 millimeter, and in the chest leads normally it should be more than 10 millimeter. If the and the height of the in the chest lead, the height should progress from, height should increase or progress from B1 to B5. It should progress from B1 to B5. I mean to say, height of the R wave should increase from B1 to B5. Okay. So if in the limb leads, if it is less than 5 millimeter in the limb leads or less than 10 millimeter in the chest lead, this condition is called low voltage ECG. If it is less than 5 millimeter in the limb leads and less than 10 millimeter in the chest lead, this condition is called low voltage ECG. Low voltage ECG. So there are lots of causes for low voltage ECG. Actually we are measuring the electrical activity of the heart by putting the electrodes over the body surface in the graph paper, and if there is anything that that interferes the transmission of electrical activity or electricity from heart to the electrodes, those condition causes the low voltage ECG. Like if there is collection of the fluid in the left side in the pericardial space, that condition is called pericardial effusion. The pericardial effusion. If there is collection of fluid in the left-sided pleural space, that is called left-sided pleural effusion. Left-sided pleural effusion. Another condition is there is collection of the blood in the left side. That condition is called left-sided hemothorax. If there is collection of the air in the left side, that condition is called left-sided pneumothorax. Pneumothorax. Or left-sided emphysema, subcutaneous emphysema. Or simple obesity can interfere the activities. Obesity, or in case of generalized obesity, or in case of hypothyroidism, there is myxomatous tissue, mucopolysaccharide tissue deposition in the subcutaneous space. Those also can interfere the transmission of electrical activity. Hypothyroidism. So these are the causes of low voltage ECG, that is less than 5 mm in the leaflets and less than 10 mm in the chest leads. These are called low voltage ECG. And I have told that there should be progression of the R wave from V1 to V6 in the chest leads. If there is non-progression or a simple non-progression can occur in the non-progression of the R wave may occur. That is non-progression, but the terminology is poor progression. No increment of the height of the R wave from V1 to V4 or V5 or V6. R wave. There are some conditions in which non-progression of the R wave height can occur, like COPD, chronic obstructive pulmonary diseases, or anterior wall EMI. Anterior wall EMI, or it may occur in left bundle branch block. Left bundle branch block. Now come to the height of the R wave can be big. Height of the R wave can be big. So tall R wave can occur. Tall QRS complex. Tall QRS complex can occur in so many conditions, like it may be due to improper calibration. Improper calibration. It may be due to bundle branch block. Bundle branch block can be right bundle branch block or left bundle branch block. It can occur in ventricular hypertrophy. Ventricular hypertrophy. Right ventricular hypertrophy or left ventricular hypertrophy. So tall QRS complex or height of the R wave may be abnormally tall in conditions maybe due to improper calibration of the ECG machine, bundle branch block which may be right or left, and another condition maybe there may be ventricular hypertrophy, that may be right ventricular hypertrophy or left ventricular hypertrophy. And it can also occur in WPW syndrome. It can also occur in WPW syndrome. Now, how will you differentiate between right ventricular hypertrophy and left ventricular hypertrophy? See P1 and P5 or P6. In V1, if the QRS complex right ventricular hypertrophy, in V1, young pattern in V1 and W pattern in V5 or V6 is in this shows right ventricular hypertrophy. But in case of left ventricular hypertrophy, the ECG phase is totally opposite. W pattern in V1 and M pattern in V5 or V6. This is This is right bundle branch block. This is left bundle branch block. Right bundle branch block is M pattern in P1 and P5 or P6 W pattern. Here looks like in left bundle branch block, W pattern in P1 and M pattern in P5 or P6. This is left bundle branch block. So another cause of tall RVP is ventricular hypertrophy. Ventricular hypertrophy can be right ventricular hypertrophy or left ventricular hypertrophy. So in right ventricular hypertrophy, normally in the P1, also this right ventricular hypertrophy, normally in P1, the QRS complex maybe this is normal. This QRS complex normally is negative. And in case of right ventricular hypertrophy, there will be normally RVP is very small in case of V1, very small. But in the right ventricular hypertrophy, the height of the R wave is tall. Height of the R wave is increased or tall R in the V1. So this is right ventricular hypertrophy. In case of left ventricular hypertrophy, there are so many criteria. The commonest criteria is voltage criteria. Voltage criteria is commonly used, that is also called Sokolov criteria. In the height of the depth of the S wave in B1 plus height of the R wave in B5 or B6. It should be more than, if it is more than 35 millimeter, then S in B1 plus height of the R in B5 or B6. If it is more than 35 millivolt, that is 35 millimeter, this condition is called left ventricular hypertrophy. Or simply, if height of the R wave in P5 or P6 is more than 27 millimeter, this ECG will also suggest left ventricular hypertrophy. So we have talked about the normal figure of the QRS complex. This QRS complex, poor progression causes a poor progression, low voltage QRS complex, tall QRS complex. Now we'll talk about the width of the QRS complex. QRS complex normal width is up to 0.11 second. Sometimes QRS complex is narrow. Sometimes QRS complex is maybe wide if it is more than 0.11 second. Narrow QRS complex occurs in SVT without aberrant conduction. Aberrant conduction. QRS complex may be narrow, may be wide. Narrow occurs in SVT without supraventricular tachycardia, without aberrant conduction. And wide QRS complex, wide QRS complex, it occurs in ventricular rhythm. Like idioventricular rhythm, ventricular tachycardia, ventricular ectopic, and here bundle branch block, that may be right bundle branch block, that may be left bundle branch block. Narrow QRS complex. As for the SPT, if you want to talk about the SPT, it looks like this. These are the SPT. In supraventricular tachycardia. Regarding this, I am discussing only about the ECG criteria. There is narrow QRS complex is narrow and PUF may not be visible. PUF may not be visible and QR intervals are regular. PUF may not be visible, QRS complex are regular, QRS complex are regular and narrow. The drug of choice for the SPT is adenosine. This is the drug with shortest half-life, that is 9 seconds only. Drug of choice for adenosine is 9 seconds and the contraindication of this drug is COPD and bronchial asthma. And there sometimes in the QRS complex there may be abnormal waves. Abnormal waves like abnormal shape and waves like delta wave and Osborne wave. Delta wave and we also see J wave. Delta wave and J wave. Okay. And delta wave is this is slurring in the R wave. This occurs in WPW syndrome along with short PR interval. And J wave, there are so many causes of the J wave. P. This is J wave. This J wave occurs at the beginning of the ST segment. And this J wave occurs in so many conditions. It may occur in normal person. It may occur in early repolarization syndrome. It may occur in Brugada syndrome. It may occur normal person in early repolarization syndrome, in Brugada syndrome, and it may occur in hypothermia. When temperature is body temperature falls below 30 degree centigrade, hypothermia. If there is J wave due to hypothermia, in this particular condition, this J wave is called Osborne wave. In this particular condition, this J wave is labeled as Osborne wave. So we have talked about this during the abnormal shape in the abnormal waves. Also we can say abnormal waves in the QRS complex if there is in the R wave, beginning of the upstroke of R wave, delta wave which occurs in WPW syndrome, and there is at the end of the QRS complex, that condition is called J wave. If so many condition it occurs J wave, particularly if it occurs in the hypothermia, that condition is called Osborne wave. Now we'll be talking about the axis of the QRS complex. Axis. normal axis. Actually, the axis, I'll talk the axis only in brief only, because whatever may be the axis, it is not going to affect the management of the patient. So only theoretically this axis is necessary to know. It does not affect the either it is left or axis, right axis, or northwest axis. It does not affect the management of the patient. Normal axis, we look at the lead 1 and lead 2. If QRS complex, normally in lead 1, if QRS complex is positive QRS complex in lead 1 and positive QRS complex in lead 2, this is normal. If there is left axis deviation, lead 1 will be positive, QRS complex will be positive in lead 1, QRS complex will be negative in lead 2. If there is right axis deviation, QRS complex will be negative in lead 1 and it will be positive in lead 2. So left axis deviation, lead 1 positive, lead 2 negative. Right axis deviation, lead 1 negative, lead 2 positive. These are the axis deviation. Then what are the causes of left axis deviation? Left axis deviation, it can occur in inferior wall EMI. It can occur in WPW syndrome. Similarly, right axis deviation can occur in anterior wall EMI. Also in WPW syndrome. Right axis deviation can also occur in WPW syndrome, and also it can occur in congenital heart disease like atrial septal defect. It can occur in atrial septal defect also. Now after this we'll talk about in short about the WPW syndrome. WPW syndrome is one of the pre-excitation syndrome where we are talking there may be there is always short PR interval, delta wave, short PR interval, delta wave, and wide QRS complex, wide QRS complex, and there is axis deviation, axis deviation. In WPW syndrome, the pathway can be, it is because of the presence of accessory extra pathway, extra conductive tissue. It can be right-sided pathway may be there, or left-sided pathway may be there. Left-sided pathway may be there, depending upon the side of the pathway. ECG, the morphology of the ECG varies. With this information, we come to the end of ECG Basic Part 3.